Let me ask a question of Amir about this allelic ratio and how it impacts further discussion. So Amir, are there patients who have such a low allelic burden of FLT3 and maybe other mutations where allotransplant should not be recommended?
You know, and again, I think if you ask multiple different leukemia doctors, you're going to get a series of potentially different answers. I, having trained with Mark, have learned to have a very healthy fear of FLT3 disease, specifically FLT3-ITD disease. It tends to relapse, it tends to come back very quickly, and relapse disease is oftentimes difficult to overcome, although we do have much better targeted drugs right now to manage them. I tend to be more aggressive when I see FLT3-ITD disease and tend to recommend midostaurin with induction chemotherapy followed by transplantation. And thereafter, actually, institutionally, we recommend post-transplant maintenance therapy. And Mark Levis and a colleague of mine at Mass General Hospital have led a very large phase 3 study, which we hope to have results from in the fairly near future to let us know ultimately if a very effective, potent, selective FLT3 inhibitor is going to be helpful in that regard. So I have a healthy fear of it. I recommend aggressive therapy, and I recommend a good amount of FLT3 inhibitor therapy spread throughout the course of treatment.
So looking more closely into the methodologies of transplant, which is what I've been spending my time doing. Not all transplants are the same, and not all transplants offer the same low toxicity. The donor matters, the prep matters, the circumstance matters. And so Harry's point, I think, is a good one. Low allelic ratio, NPM1, no DNMT3 present. Boy, particularly if all I have is a 6 out of 10 Labrador Retriever as the best donor. Oh, you know, I am now, and I'm being facetious, but in fact, there are donor combinations that are kind of like that, female into male. You know, not so. It's not a certain question. Every patient needs to be examined carefully for a decision like that. Of course, you know, we're all about transplant here, but in fact, yes, I think it's a good point to reflect on it.
Yeah, Mark, go ahead, Gail.
Sorry, I was just going to react to something that Mark also brought up, which I think is really important, that, you know, we're looking for ways to simplify things that aren't simple. And I think that for people who aren't living and breathing AML every minute, you're kind of like, okay, I see FLT3, I got to hammer, you know, I got to hit that with a FLT3 inhibitor. But if I see an NPM1, well, then I don't have to worry so much. But then wait a minute, what if there are 4 other mutations plus or minus the DNMT3? So I think it's worth the point to just not buy into any reductionist view of this. You can't just say FLT3 transplant, NPM1 don't transplant. There are too many other factors, whether it's concomitant mutations, allele burden, donor type. It's really complicated. And I think that the take-home message is that all of this separation into mutational subcategories, the availability of targeted inhibitors, this doesn't actually make for a simple bingo game here. And I think that some of these patients really are being told, well, if you have this, you got to do that. You have this, you've got to do that. And actually there's a more complex total picture that needs to be looked at. And not to mention that if you look at even subtypes, for example, of DNMT3A mutations, that's complicated. It's complicated to read the report. Is this the bad one, R882? Which one is it? It's a lot to ask if AML isn't front and center on your daily routine.
And to that point,
I agree with all those comments. And I think, you know, I have patients in my clinic who have had low allelic burden FLT3 and nucleophosmin, no DNA methyltransferase 3A, and are long-term survivors after just consolidation, typically older patients in that group. You know, I think that for our viewers, the data that the faculty have been really alluding to is the paper in New England Journal by Papa Emanuel showing that the biggest impact of the FLT3-ITD mutation are in patients with nucleophosmin and DNA methyltransferase 3A mutations. But Gail's point about the different mutations is well taken.
And the ELN classification is another interesting point. I like it and hate it. It really consists of lumpers. They've crammed an inversion 16 in, so you can, basically a 22-year-old with an inversion 16 and no other mutations is the same as a 69-year-old with a FLT3-ITD 40% allelic ratio NPM1 mutated. Oh, that's good, is it? Really? And in fact, their own data says, no, it's not. Those do separate out. So the ELN is not something to say, this is how I treat. It gives you good prognostic information. I love it. It really does hold up, but there's so much more to understanding this.
So let me wrap this. This has been a very interesting discussion about, the prognostic significance of this mutation and many others. But let me wrap this up into maybe one concluding statement. It is incredibly complicated how all these mutations are interacting in determining the prognosis of patients. And then on top of that, you layer what your patient is able to tolerate in terms of therapy. And because of the uncertainty of all of this mutational analysis and how it impacts on prognosis, I think that's why one of the major reasons why we are really beginning to focus now on the prognostic significance of measurable residual disease, as how sensitive is that disease to therapy in determining what the long-term prognosis will be. But we don't really have time for that discussion, so I'm just going to leave it at that, if you don't mind. I hope no one disagreed with that too much.